Thank you, everyone. Um, this is my last digital health seminar series seminar, but we will definitely continue this one in hopefully October or November. My name is Sally. Hopefully, you already know me. So I'm the Digital Health Research Coordinator at BC Children Research Institute and the Women Health Research Institute at PHSA. I work with my colleague Haley. Haley, do you want to quickly introduce yourself?
Sure. Hi, everyone. My name's Haley. I work with Sally. I'm a research coordinator for the IRIS team at BCCHRI. It's great to have you all here.
Thank you. Okay, and the session has already been recorded, but first of all, I would like to acknowledge that we operate on the ancestral and unceded territory of the Coast Salish people, including the territory of the Musqueam, the Squamish, and Tsleil-Waututh Nation. We recognize their ongoing contribution to the health and well-being of the community. I also want to express my respect and gratitude for the opportunity to live, work, and serve on this land because of them. It is crucial that we honor and support the right culture and history of Indigenous people as we work towards reconciliation and improving healthcare services for all of us here.
Uh,
Yeah. Before we start, I just want to give a quick introduction of all our three amazing, outstanding speakers. So Dr. John Jose Nunez, Michael Lee, and Dr. Dwayne Tucker. So Dr. John Jose is Associate Medical Director of the Supportive Care at BC Cancer and a psychiatrist and faculty member at UBC Mood Disorder Center. His research applies artificial intelligence and data science to cancer care and mood disorder, with a focus on improving outcome for patients facing both cancer and mental health illness. His past projects include using AI to analyze clinical notes to predict cancer survival and to identify patients who may benefit from referral to counseling or psychiatric care. And Michael Lee is currently the Senior Director, Advanced Analytics at Vancouver Coastal Health, VCH. He and the data analytic team are responsible for providing analytics across the entire region to support the strategy, operation, and ultimately the better care. So throughout his career, Michael has worked in every clinical area within healthcare, from public health to surgery. His journey has led to work across all BC, Alberta, and Ontario, both in public sector and consulting role. And last but not least, we have Dr. Dwayne Tucker. He is a postdoctoral research fellow in the Faculty of Pharmaceutical Science, also at UBC. His doctoral research focuses on identifying clinical and biomarker predictor of pain outcome in endometriosis and included the development of machine learning-based prediction model to support surgical decision making. This work sparked his broader interest in chronic pain outcomes and the use of data science to generate insights and inform clinical care. So I think that's enough of me. Nobody want to hear me, just keep talking. I will pass my e-mic to our first speaker, Dr. John Jose then. I'm gonna stop share my screen.
I want to hear you keep talking, Sally. No. I just need to sharing permissions if you
Oh
don't.
yeah, I'm gonna make you the co-host and then you should be able to do that.
Perfect.
Yeah. I will highlight you as well.
Okay. My apologies. We're just trying to get it to work here.
No worry. Take your time.
There we go. Okay. Well, you gotta select the right PowerPoint
Yeah,
window.
yeah,
I
that's
think this is
always,
it. Is
that's
that
it. We
working?
can see it
Alrighty.
perfectly.
Okay, well, I will start, and yeah, I'll try to keep this around the 15-minute mark. So, hello everybody, and thank you so much for the invitation to chat today. Really, I'm happy to be here. And yeah, we already did. I think did our non-acknowledgements, but I do really just like to particularly acknowledge just the barriers that our Indigenous patients do face in the healthcare system, and I really do hope that digital health and AI approaches really can help address that. Really quick for a little bit of disclosures. Back when I was in my fellowship, some of that money originated from Pfizer Canada. I don't know if they do any AI stuff. I'm not talking about their products today. And then I also did recently start some collaboration with Amazon Canada. Again, won't be talking about any of that specific products. And then, of course, there's a little bit of intellectual bias about what I'm interested in and whatnot. Okay. So today I'm going to be talking a little bit about how I kind of see a bit of more of a general idea about how I understand the role of machine learning and artificial intelligence in digital healthcare. I'll be talking a little bit about its adoption in kind of different areas, in which case I think it could be adopted. A bit more of a general kind of a sense, because I think that's kind of helpful to kind of really understand things, but still in a bit more depth than just, yeah, let's use ChatGPT for everything, which I think sometimes is folks' approach. So to start this conversation, I don't know if folks are able to like do like the raise hand feature or whatever else, or you could just shout into the screen or whatever. But I like to ask folks if you've used AI clinically or at work, depending on your position, before something like ChatGPT came out. Yeah, am I going to be able to see responses? No, I don't think I will be. That's okay. Okay, so I asked this question a bit rhetorically because I like to bring up that AI is actually being part of our clinical practice and probably part of your job for a long time, well before the kind of late 2021, 2022 kind of time frame. So artificial intelligence has actually been around us. The grammar check in your email system probably would be considered AI. The junk mail filter, spam filter, definitely is considered AI. That's like a very well-studied algorithms in your like third year computer science class. Oops, sorry. Automated ECG interpretation is a cool clinical one that's been going on since the 80s. Arguable whether exactly it would meet criteria for AI, but I think in many ways it would. And again, we've been using that for a really long time. Clinicians here have been using Fessor, front-end speech recognition. This actually, I'm at the clinic today, so you talk in this little microphone thing and it spits out a document for you, right? Transcription. That's definitely AI. We've been using that, I don't know what, about a decade. So I bring this up because I really want to help people understand that we've been doing this for a while. And there are a lot of exciting new advances that are going to really help transform stuff. But we're not starting from scratch. We're not starting from this ground zero of like, how do we deal with AI? Well, no, we have been using it for quite some time. And I think a really important potential way to think about kind of AI adoption in healthcare is this idea between a systemic versus a point change. So when technologies are first invented, they tend to only first start with the what Silicon Valley types like to call killer use case, which I don't know if that's appropriate at healthcare setting to use that term. But a good example is electricity, which was really kind of electricity has of course existed since the beginning of the universe, but humans have been aware of it since like the late 1700s. And then it took quite a few decades, but by the 1880s, there was a couple use cases that were actually, a couple point changes that were really being deployed. So cities realized that instead of burning whale oil, which is apparently what they did before, they could use electricity to run streetlights, right? Which obviously was really useful and you could illuminate things and wasn't stinky and didn't involve killing poor whales. So they started to change electricity, and that's what kind of led to like the initial grids being deployed for cities. But at that point, most houses still wouldn't have electricity, and there was just kind of these one or two things that really electricity was being used for. There's some kind of industry stuff also at this time. But you can see that, about a few decades later, 30 whatever years later, you started to have things like electrical vacuums and electrical toasters. The above one here is a early toaster. So in other words, electricity was starting to become widespread, and it was starting to become systemically integrated into society. And now we don't even think about it. We assume that electricity is everywhere, thanks to a lot of privilege, of course, but it's very, very wide. And I think that's going to be a good way to think about AI. I think we're starting to now move from that kind of point system to a more systemic adoption. Another way that I think is important to think about AI is this kind of more gradual progression. We're not talking about going from zero AI, zero artificial intelligence anywhere, to all of a sudden we're all replaced and now AI is running society, right? This is a way I always kind of like to think about AI more generally, but this is specifically about cars. So right now I have a level 0 car. It's about over 20 years old and it barely runs. It definitely does not have any autonomization features whatsoever. But there's a good chance that your car is starting to move into level 1, level 2, kind of level, even level 3. There's some stuff. There are things right now like Waymo, which is operating cars that probably kind of in level 4 to level 5. So we're starting to see that. But this is a good analogy, I think, to how I see it really taking place within medicine, right? Initially, we have things like AI scribes. They're like useful to do a couple little features. Eventually, we're going to be moving perhaps into more of a co-pilot, really, where AI is helping us with decision making and doing things. But humans are going to be in the loop, helping them make those decisions for a lot longer. A common question, happy to discuss it more, of course, is, are physicians or I know this isn't just a physician audience, but think about your job. Are we going to be replaced anytime soon? Well, we've been using, again, automated systems to run airplanes for decades. And when I go on I'm getting on a plane next week, there better still be a pilot on that plane. And I think similarly, that's going to be the case for healthcare for quite some time to come. Really quick, I also just like when I'm giving these talks to just also give a plug for data science generally. So, I don't really have the time to go into the difference between AI and data science, but, beginning to think of like simple analytics with larger amounts of data can still be extremely useful, even if there isn't the fancy AI component that's doing non-deterministic decisions or whatever else, right? So here's just an example of a recent project of you doing that, just figuring out how people in BC Cancer move between different supportive care resources. This is not AI, but everybody I've showed this to is like, wow, this is like super cool and super useful. So data analytics generally is very useful. We should not lose track of that. Okay, so now I'll talk about kind of the way I like to think about 3 different broad categories of AI that might be helpful for you to think about, oh, how could AI, be incorporated into my care, my practice, or my position. I like to talk about extractive AI, which is where we're taking useful information from another piece of data. Predictive AI, where we're trying to predict or classify things that happen in the future, or even just classify something in front of us into different categories. And then, of course, generative AI, which I think we all have probably have a little bit of exposure to that, but I'll talk about that into just a little bit more depth. Okay, so extractive AI can be a really powerful tool. Then the idea is really that we're retrieving a subset of data. Within the healthcare setting, I think a lot of this popularity, and if this is a big, if you've ever came across Raymond Ng, this is a lot of his projects have shown like really cool ways to do this. But is to extract data, for example, from clinical documents, right? A lot of clinicians are very bad at filling out forms correctly, or they might not, select what diagnosis somebody has, so on and so forth. But folks will usually write it in their clinical document, and we can use AI to pull that diagnosis out, and then, for example, know how many of my patients that I've seen, last 100 patients have this diagnosis. Or here an example is I might want to know, for example, how many patients have struggled with alcohol use. And this works really well, generally speaking. AI is generally very good at this. We can't just use simple string searches in most cases, because somebody might write something like, oh, the patient does not have a alcohol use disorder, right? So we need something a little bit fancier. So AI is good at this. And often we can do pretty cool projects with this. If you do want to do something like this, though, an important thing is you usually need a gold standard, which is where when you're designing the algorithm, you need a human to first go through and annotate at least a few examples. And then you could develop your AI and know how well it's working based on this gold standard that was developed. So a little bit of manual work to build systems like this, but can be really helpful. Predictive AI, again, is this idea of trying to predict things that happen in the future, or trying to classify things that we might want to know about. I'll give some examples, but I think the cool thing about predictions is that sometimes you can often do them without data that's exactly related. I'll give you an example about that. But generally, we need lots of data to do this sort of stuff. Sometimes folks come to me and they're like, oh, I have like 30 patients' data. Could do a machine learning project? And then the answer is usually probably not, because that's not quite enough data. But hundreds are usually, for some machine learning algorithms, perhaps sufficient. Thousands are better, but generally you need more data. But there are kind of some ways around that. which kind of, that can be used if you don't have too much data, but often that's the case. So an example of this is our still, I can still call it recent-ish project at BCCHR, where we're using the initial oncology consultation document and we're predicting whether somebody needs to see a psychiatrist or needs to see a counselor in the next 12 months. The reason being that oncologists are often really busy during that first appointment. They often miss a bunch of people who have really would benefit from a referral. And then by the time I see them as a psychiatrist, it's like way later and they're like super depressed, maybe giving up on chemo or something like that. That's what, triggers the referral. And if we do this ahead of time, we potentially help people a lot faster and sooner. So we're quite excited about this. We also had another similar project predicting the survival of patients with cancer, also from these documents. And that actually showed that it could predict that really well, which is also interesting from an ethical and other lenses as well. But and you could do this really, again, you could predict anything you want as long as you have the data for the outcomes and the inputs. So some other examples, I've done some of this work, but it's again, pretty common, is trying to predict whether somebody's going to respond to a medication. As a mood disorder psychiatrist, I do this with antidepressants. And you can use lots of data, right? You can use genetic data, clinical data, what sort of symptoms you have, imaging data, you can do brain scans and feed that to the algorithm. The more related or the better the data is, the better the predictive performance is generally going to be. You could get somebody to draw a picture and use that to predict whether the antidepressant will help them, but probably that's not going to be a really useful piece of data. But you can do lots of cool stuff regardless. And yeah, I think really there's lots of examples about this throughout. We actually currently do have a trial going on for using machine learning to actually help figure out whether we need to give somebody an extra medication or not. So we're quite excited about that. And then last but not least, I'll just talk a little bit about generative AI. Again, I think it's really cool. It's been really cool being a kind of AI researcher. I started 10 years ago or even longer, depending on how you want to define it. And then all of a sudden, generative AI comes out, and everybody's like, "Whoa, AI is so cool!" And I was like, "Yeah, AI is really cool. I mean, I've known that for a while, but nobody, initially we were all just these kind of like nerdy people in the corner, and now I'm still the nerdy person, but maybe a little bit less at the corner sometimes, at least. I still probably should be sent to the corner most of the time, but anyways. So the idea for generative AI is really you could do things like taking one piece of data and producing another piece of data, and that's really useful because it allows more easy human language interactions, and so you could do stuff like expansion, summarization, defining, generating instructions. The big problem with all AI applications, of course, because we don't necessarily know what they're going to predict usually, is the idea about the overconfidence and the potential for inaccuracy. And we call that hallucinations these days in generative AI, which is very fun for a psychiatrist. But so I think we really have to be careful with these applications within the healthcare context. We need to ensure that they aren't going to be overconfident, they're not going to hallucinate and lead to bad things happening, which very well can happen. But also about privacy considerations, right? Sometimes I'll hear about somebody who's like, "Oh yeah, I'm gonna put the patient's data into ChatGPT." Please don't do that. Like that goes to some big American company that's then going to use that data to train their models, and you're not going to know what's going to happen to your patient's data. So it's really important to have these privacy considerations. So for example, we have a system at BC Cancer on the website that helps people navigate the website. And I think there's a lot of, and I have a bunch of other projects also doing similar stuff. People like to have conversations instead of like click, 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 click. So I think there's a lot of cool applications for using chatbots and a more conversational approach. Another neat idea, or not neat, well, it is a neat idea, but another thing that's becoming very, very widespread is AI scribes. We do currently have these deployed across the different health authorities, and so I was like a minute late logging on to this because I was seeing a patient where I was using an AI scribe with their permission, of course, and so now the scribe's written the note, so hopefully I won't have to. I will have to edit a little bit, but yeah, this is a really good example of generative AI, and I think we're going to be seeing this expanded to being able to incorporate more information to really help with the documentation task as we go on. But but these generative AI approaches are really neat. And then I'll wrap up my portion before handing it off just about the idea of agentic AI, because I think that's something that you may have heard of, and I think our definitions are still still figuring out exactly what we want to mean by everything. But I think really to me, the idea of an agent, because most AI systems, I probably they are an agent of most conversational agents, for example, would be an agent. But I think really what this is really starting to think about is the idea of having our AI systems interconnected with each other, right? So for example, could we have an agent that can read your email, help draft a response, but then also, hook up to a calendar and book the meeting for you, so you have to do that yourself, but also tell your colleague, okay, well, here's the appointment that we've booked, and right. So I think that's kind of my idea of really what agents are doing, kind of more interconnected systems that are able to do more things at once. And I'm really excited for these to become more developed. I think a lot of honestly what the issue right now with AI, there's many, but having systems actually interconnect with each other is really a big barrier right now, as the technology continues to really improve really quickly. Okay, so yeah, in summary, to kind of wrap up, I think AI has already been used for these specific point cases, and now is becoming more systemically used within healthcare, and it's very exciting. I think it is going to be more of like instead of a specific tool, more something that's helping different things all at once and more integrated. I talked about extractive, predictive, and generative as one classification scheme for the different things that AI can help with. And I think all of us here on this call, our expertise are going to continue to be very integral to the adoption of AI in healthcare for quite some time to come. And I really don't expect that we're going to see this, wholesale replacement of humans in the next year or two, as some people are predicting. But of course, what do I know? And with that, I'll thank you all so much and turn it over to the next speaker.
Thank you so much, JJ. And for those who don't really know JJ, he's also our chair for our AI in Research Working Group. So if you want to present or if you have any idea, feel free to go on our PHSA website and you can know all our amazing work about this group. So yeah, maybe it's a time now, Michael, you can talk about your AI advancement. Thank you.
Yeah, so continuing on where JJ left off, I'm going to talk about advancements in general out there. Actually, quite a while ago, NVIDIA had predicted all of this happening. So they had already talked about, I believe in 2012 or so, perceptive AI, generative AI, and agentic, and now physical AI, which is the outer edge of what's being worked on, self-driving cars, etc. At least from an NVIDIA perspective, because that's where they sell most of their chips. But I'm going to talk about agentic for a second here, because just riffing off what JJ mentioned, it is a little bit different than generative AI. So there's Copilot agents now. You can actually build an agent in Copilot that allows you to point to a SharePoint or websites. And that is what I would call a very light AI agent. There's other examples in enterprise where agents have been built with specific roles. So I would say the difference between an agent and Gen AI chatbot generally is that the agent's going out there and doing something, as JJ said, more substantive than just chatting with you. And so there's entire data governance, data enablement that has been built out based on, say, 20,000 pages of policy. And there's a bot that is a policy analyst. There's an agent, that's doing the metadata work. And then there's an orchestrator agent that connects all of those things together. This is a continuation on that slide, the car slide JJ showed. Something that's discussed at Vector Institute, for instance, is around this concept of scaffolded cognition. And what I mean by AlphaGo Move 37 is that was the move that the AI made that beat a human player at Go. And no one really understands why the AI made that move, even still. And everyone at the time, all the grandmasters, thought that would mean the computer would lose. It didn't. And so now folks have gone back and studied when that move is the right move to make. And so it's still a bit black box, but this concept of scaffolded cognition is really emerging as well, using AI to teach us as opposed to doing something for us outright. So it's sort of an expansion of the human in the loop concept in a way, that maybe it's not just a human checking what an AI produces, but actually having an AI coach us towards a goal so that there's not this kind of cognitive loss that occurs when using Gen AI, per some of the literature I'll show in a second. So you see this move from vibe coding to coaching bots for coding. And I think both are valid, but you'll see more of this in the future. Important articles to look at. I'm not going to get into it too much, but I am a bit of a technology Luddite despite what I do. And there's some warning signs here. The accumulation of cognitive debt when using ChatGPT. Essentially, people don't know what they're producing all the time. You can read that article. There's this concept of AI slop, that is, there's more AI out there now in the universe. On the internet, AIs are training on other AIs. And so it starts to get a bit of a circular loop, because how do you know what's actually real? If you think about images, that starts to get a bit weird. And then Apple Research published an article called The Illusion of Thinking, which shows that large language models actually collapse at a relatively simple problem, like the Towers of Hanoi, which is a classic computer science one that can be coded with a few lines of code using recursion. So it's not good for everything. I think it's being refined gradually. These are actually very recent articles too, and I would urge that you take a look at them so that you have a balanced viewpoint on all of this. One thing though that hasn't really been, and I guess it gets into the scaffolded cognition piece a little bit, but what is the best UX UI for AI tools? I think that's something we're all trying to figure out, how to reduce this sort of cognitive debt, et cetera, and what is the right way to interface with an AI. So I'm going to go into some of what we've done internally within BCH. We've started by bringing clinicians closer to data by giving physicians, via terms of use, direct access to the data that we hold. And then we started working on this concept of talking to your data. So how do we use large language models to understand what's in clinical notes? Throughout all of this, just a side note, we have a buy first approach because building this stuff is really hard. And that's nuanced because oftentimes, as you'll see, you buy a product and you have to configure it. But we're rapidly moving away from 1,000 lines of Python code for every text analysis that we do. And you'll see through this presentation that we're now kind of there. So this was based on a model from the Mayo Clinic around this sort of concept of bringing physicians closer to data. In the past, it's always been this email back and forth between an analyst and a clinician. And without visibility on the data sets, it's really hard to identify opportunities from a clinical standpoint, is what we found. And the nuance of, say, a drug is ordered. We were doing a project on clozapine. So JJ, I know you probably know about the nuances there. And the order was in bulk, but the analyst had no clue that that was the case because the analyst doesn't prescribe it. And the psychiatrist, Dr. Brian Chow, working on it, actually, he said, well, that order is just to order the drug. It's not how it's administered. So we need to look somewhere else for that. Very detailed example, but very, I think, prescient example of why clinicians having access to data directly is going to be a key in the future. So what did we build? Well, there's this problem in the AI ecosystem, as JJ alluded to. Public AI is not private by nature. And so we can't put things into, say, the web version of Copilot or ChatGPT, et cetera, in terms of our clinical data. And then there's VCH, or health authority, shall we say, approved AI. So we have an internal Copilot. That still isn't approved for use with PII. They are working on that, from what I hear, on the privacy side. However, the concern now is that it's not fine-tuned enough to actually be responsible. So it isn't necessarily an issue of privacy, but of efficacy. So in looking at all this, we actually are very close to naming our version of solving this problem. I think we'll land on Okta. So the middle thing there was Okta, Cappy, and Otter. Those are the candidates. I think it'll be Okta. But what we built in an Azure Databricks environment is a private platform infrastructure where we can use any large language model that we can fine-tune ourselves. It's built scalable and modular, and it uses fit-for-use processing, so it doesn't actually even trigger any need for NVIDIA GPUs, because a part of it is no one said we need to do this real time. So the closer you get to real time on this stuff, the more processor heft you need. And so we're able to do this just on normal serverless clusters. So going to go into it a little bit more. Sorry. The architecture is very modular. For those that are more technical in the audience, the raw data is built into data engineering jobs using Azure and Databricks. And even when we're using Python to do certain things, the files are all split up into Databricks workspaces and modularized as well, so that a data scientist can come in and look at it even if it's not the same data science working on it. There's a lot of technical detail here. I'm sure some are interested in this. This displays the modularity. So upsert is basically a change data capture function, and it allows us to not have to reload all the data. It can actually take the delta, and that's a standard function. The PII detection itself needs to use AI, so that has its own complexity. But the real key here is around the AI query. So Databricks acquired Mosaic for $1 billion a while ago, and this is part of the technology of being able, and you'll see in a bit, to use this kind of query directly within a normal query. Now, that requires some nuance and some skill in order to do that, so it's not opened up to everybody. By the way, this is not a Databricks ad. It just so happens that's the environment that we use. I'm sure that other environments like Snowflake, etc., will start building out these kind of things if they haven't already. So we'll see more modularization in general of using AI. JJ made allusion to burden of alcohol, so I'll show some of this. Usually Dr. Grafstein speaks to this, but I'll do my best. Essentially, when we look at normal structured data, we got an alcohol diagnosis prevalence of about 1.4%. When we started looking at the notes, which were trained by Eric himself, and fine-tuned rather, not trained, we got a prevalence of about 8%. So another example is around e-scooter. It's such an emerging issue in terms of trauma and public health that there isn't really good coding around it. And so we're able to look at e-scooters in ED triage notes similar to alcohol, but also look at other facets like was a helmet worn, etc. How fast was the person going? So the query itself is only about this long now. And part of that is because you'll see here we're calling Llama. But through this AI query function, you no longer have to deal with all of the model platforming and all of the model setup, which is individual to each model type for those of you that have done it in the past. And so all of a sudden, this becomes a lot more powerful because there's things in the background that can be done, like automated model selection, et cetera, to find the best model for your use case, other things like that, because no longer is so much effort spent on just trying to figure out how to even get the model to run. So you see, for those of you that are not that technical, it's just not that long anymore. So our first use case with the burden of alcohol was over a year of work. It took 6 months to even figure out how to get data out of Cerner. It was, Cerner stores text data in formats that are not immediately obvious. So they don't tell you if it's rich text or XML or other things like this. So we had massive parsing issues with words run together or weird characters, etc. And we actually had to use machine learning in order to even get the text data out. Once we did that, though, we were able to do and build the modular approach that it showed. And subsequent use cases have now only taken 2 to 3 weeks of a dedicated data scientist time in order to turn around another piece of AI work. Some of that has included barriers to discharge. We're also putting a clinical summary into Cerner using AI for the Texada electronic medical record cutover from IntraHealth. And that's a sort of test bed for looking at, can we do that with Vancouver Community, which is a much bigger set of records. And so really, I'll leave you some key takeaways. The partnership with clinical is key. The sort of co-design of all of this work. It's turning out the fine-tune is way more important than the model selection by a large margin. The models are all converging to kind of the same thing. But for instance, when Eric was looking at alcohol cases, some of them would say things like patient binge drinks was not this weekend. So what does that mean, right? Even a human can't really understand that. And so being able to flag those kind of ambiguous cases to make a decision about whether or not long-term drinking is what's being looked for, as opposed to this specific ED encounter, is a clinical judgment call. The technology is changing rapidly. Read those articles I mentioned. I think they're really good. At the end of the day, data literacy is still the foundation. So finding an opportunity, if you're clinical, to work with data, and the system impacted and how it might be sustained is really important. Oftentimes, we don't make the changes that we find in the data. And this is now very onerous from a skill set and like an advanced use case standpoint. The type of people that can do this work are not, they don't grow on trees. And the cost of building the infrastructure, although on the margin is not crazy, it's still very computationally intensive. So it's sort of like vis-a-vis a CIHI report or a DAD extract or something like that. All of a sudden, things are more expensive and more time intensive. It becomes more important to think about, well, what's the impact and how are we going to get the impact in clinical care, not just produce a fancy text analytics thing, whether alcohol or e-scooter or other. I'll leave you with this one thought that's not on this slide, and that's what we're looking at is how we move this work provincially. We do believe with the current admin reviews going on and cost containment that this needs to sit somewhere at a bridge between research and improvement and enablement of quality within health authorities. And so part of what we're toying with is, can we sustain this work via research funding? One use case we're looking at right now is working with Dr. Harvey Hawes to figure out if we can automate some of the chart review process for the trauma registry. So in some cases, there's real cost savings, because if you're thinking about starting a research project with chart review, that probably no longer needs to be the case. And so when you look at the labor resources spent there, could we spend it using analytics, text analytics instead, and building a slightly different methodology? I'm currently looking at that for one of my research projects via University of Toronto, where we're trying to measure ethnicity from a culturally sensitive lens. So that involves having a free text option for entry, and then we would need a place to be able to analyze that. So, yeah, I'll stop there. That's really what I think the future looks like with this. And do think about the things that I mentioned. I guess over to you now, Dwayne.
Thank you so much, Michael. Before we move to Dr. Tucker, I just want to mention there are some very good questions in the chat, and feel free to take a look, and let's hopefully we could answer. And then we will try to have a Q&A at the end. It depends on the time we have. So Yeah. We can just see your desktop so far, Dr. Tucker.
Okay. Okay. Are we good now?
But with speaker, we can see your notes on the
You can
speaker.
see my notes.
Yeah.
Hold on.
Yeah, take your time.
Hold on.
Yeah.
Maybe from start. Are you still able to see my notes?
Not yet. I don't think you're sharing.
Oh, hold on. Wow.
If you need, I can also share the screen for you.
Okay. Can you see?
Yes.
Are you seeing my notes now?
Nope, looks all good.
Okay, all right.
Okay.
Sorry about that. Hello, and thank you again for the opportunity to present in this series alongside these two outstanding experts in the field. And I'd also like to acknowledge that the land on which I live, work, and play is the unceded and shared territories of the Musqueam, Squamish, and Tsleil-Waututh First Nations. Now, for my talk today, it will take a slightly different direction, but I'll start with a brief introduction to machine learning, though the first two presenters have already covered it well. Next, I will discuss the endometriosis pain index, which is a machine learning prediction model that I developed as part of my PhD. Then I'll outline the planned next steps for this model and finally conclude by highlighting key strengths and concerns when applying machine learning in clinical modeling. So machine learning is a subset of the broader umbrella of artificial intelligence. And as you would have gleaned from the previous presenters, it uses computer algorithms to find patterns in the data and then use this learned information to make predictions in new or unseen data. Now, notably, it learns from examples in the data rather than relying on explicit instructions from the users. And explicit instructions would be in the form of formulae or rules. And despite gaining significantly more attention within the last 15 years or so, machine learning is actually not a new concept and actually dates back to the 1950s. Now I will give an overview of how I use machine learning to develop the endometriosis pain index. Starting off first with a brief introduction to endometriosis. It is defined as the presence of endometrium-like tissue or lesions outside the uterus, as illustrated by the red deposits in the figure to the right. It is characterized by pain, examples of which include dysmenorrhea, non-menstrual pelvic pain, dyspareunia, and poor quality of life. Endometriosis also affects approximately 10% of reproductive aged women and an unknown number of gender diverse individuals. Now, surgery is a common treatment for endometriosis pain and can be broadly categorized as either conservative or definitive. Conservative being the removal of the endometriotic lesions, and definitive being the removal of uterus with or without fallopian tubes and ovaries. Now, despite surgery being an effective treatment for endometriosis pain, there's still a portion of individuals who experience unfavorable pain-related outcomes after surgery. In fact, according to these studies and others, around 11.8% experience no pain reduction, 20 to 38% experience persistent or recurrent pain, and up to 50% of those who undergo conservative surgery will have to undergo reoperation within 5 years due to pain recurrence. Now, these numbers are alarming and truly underscore how important it is to preoperatively identify individuals who might not achieve better functioning and improve pain-related quality of life after surgery on a more personalized level. Yet at the outset of our study, there hadn't been a reliable, validated, predictive tool for pain-related outcomes, or pain-related surgical outcomes rather, for endometriosis. And this gap could largely be due to two critical challenges that we've noted. The first being the lack of standardization in how the clinical data is collected and reported, and second being the complex nature of endometriosis itself, which involves a range of symptoms and presentations which make it difficult to make accurate predictions. Fortunately, at the BC Center for Pelvic Pain and Endometriosis, we have access to the endometriosis pelvic pain interdisciplinary cohort, or EPICohort, sorry, for short, which is a longitudinal cohort that undergoes extensive pain assessment. And that, with the advancement in computation and access to AI tools like machine learning, we can better attempt to map the complex patterns in the clinical data to make accurate predictions of pain outcomes after surgery, after endometriosis surgery. So therefore, the aims for this project was first to employ machine learning to develop and internally validate a clinical prediction model for poor pain-related quality of life post-surgery, and then to build an interface for interacting with the developed model. For this study, we used prospectively collected registry data from the EPIC cohort, which included individuals who visited the center between December 2013 and December 2020. For our outcome, our outcome was the pain-related quality of life as determined by the pain subscale of the Endometriosis Health Profile Questionnaire, or EHP30 for short. And this, of course, is a validated endometriosis specific questionnaire, which range from 0 to 100%, with 100% being worst imaginable pain-related quality of life. However, the primary definition for the outcome was based on the 75th centile interpretation or cutoff for a severe or poor pain-related quality of life in North American populations, and that is a EHP30 score of greater than 59%. The study included participants between the ages of 18 and 50 years old with endometriosis diagnosis who prospectively underwent surgery at the Center for Pain and who also completed the EHP30 questionnaire before surgery as well as during the follow-up period. Now, in selecting potential predictors for the modeling, we reviewed the literature for variables that were prognostic of worse outcomes in endometriosis, and that in combination with consultations with endometriosis experts at the center, we shortlisted 32 baseline candidate predictors of varying subtypes, as noted here. And just to provide an overview of our analysis workflow, so we had a total of 650 eligible participants, and then proceeded to do a very traditional machine learning data split where we partitioned 75% of the total data to train and develop the model. So that was 488 participants, with the remaining 25% being set aside as an independent testing cohort. So that was 162 participants. Then we chose 3 popular machine learning algorithms, and these were ElasticNet, Random Forest, and Multi-Layer Perceptron Neural Network, or Neural Network for short. Now, within our modeling framework, we focused on the top 10 most influential or important predictors to keep the model practical and simple and tune the model parameters for optimal performance. Now, to explain parameter tuning more clearly, I like to use a baking analogy. So think of the machine learning model as a cake and the parameters as the ingredients. Tuning is like finding the best recipe by trying different combinations of the ingredients to make the most delicious cake, which in this case is equivalent to the best performing model. And once And from there, we select the version of the model that performs best. And then taking these final models, we then use them to make predictions in the testing cohort, and their performance was summarized using 3 metrics. And these include discrimination, which is the model's ability to correctly classify between people, correctly distinguish between people who will have a poor outcome and those who will not. Second is calibration, which measures how closely the model's predicted chances or probability matches with what actually happens. So for example, if the actual probability of an individual experiencing a poor outcome is 25%, a well-calibrated model will predict a value that's close to 25%. And lastly, we looked at net benefit, which measures whether using the model actually helps to make better clinical decisions compared to not using the model at all. Now, just to describe the training cohort, as previously mentioned, it included 488 participants. The median follow-up time after surgery was 18 months. Mean age was 34 years. 74% of the cohort was white, and 75% underwent conservative surgery. And lastly, 16% had the outcome of interest, which was a poor pain-related quality of life at follow-up. Now, without going into details about all the summary metrics for all the different algorithms, I just want to highlight that the random forest emerged as the overall best performing model and thus is presented as the endometriosis pain index. And it utilizes these 10 clinical predictors to predict the probability of a poor outcome after surgery. So these include baseline quality of life or pain-related quality of life, the type of surgery that an individual will undergo, depression, anxiety, and pain catastrophizing scores, which are all psychological measures. And of course, abdominal wall pain, pelvic fibromyalgia, whether someone is a current smoker at the time of surgery or pre-surgery, I should say, back pain severity, and of course, race and ethnicity. We then created an online user interface for the model, which was deployed using our Shiny app, which is a package within the R universe. And this slide shows the current landing page containing a brief overview of the study and instructions on how to use the tool. So this is what the actual online calculator looks like, and users would input the values for the patient factors on the left panel there, which is just the predictors that I mentioned in a previous slide. And then the model will make predictions that will be visualized in the right panel here. Yeah, in the right panel. So for next steps for the EPI, external validation is crucial. Now, the model was developed using data from one center in BC, so it's really imperative to assess how well it performs in other populations that are more diverse. So this includes validation in other Canadian cohorts, as well as internationally. And proceeding with these type of analyses will give us a better idea of how transportable the model is. So to summarize, the endometriosis pain index shows promise as a predictive tool for poor pain-related quality of life post-surgery, and pending further validation, it could support shared decision-making discussions between patients and gynecologists, and it could help to optimize surgical candidacy, potentially helping to reduce unnecessary surgeries and improving outcomes when used in tandem with other patient-related factors. And lastly, it could help to manage patients' expectations of potential surgical outcomes for pain. I also wanted to highlight some strengths and concerns for machine learning in clinical modeling, starting with strengths. Now, in general, machine learning models are better at finding complex nonlinear patterns in clinical data than traditional statistical methods. As JJ mentioned, it can be applied to many types of health data, including clinical records, imaging, genetics, etc. And it can help personalize predictions and treatment recommendations for individual patients, as what we are trying to achieve with the endometriosis pain index. And lastly, machine learning models can be continuously updated as more data become available, allowing for fine-tuning to improve real-world decision making. And concerns include, first, models need to be trained on sufficient data. I think JJ touched on this point as well. And secondly, the machine learning models often work as black boxes with no formula coefficients. So this sometimes make it hard to understand how predictions or decisions are made, which can limit trust. However, in recent times, there are some workarounds for this issue. And third, unfortunately, models are only as good as the data it's fed on. And so if training data lack diversity, predictions may reinforce or worsen certain health inequities. So lastly, I want to extend a thank you to my co-supervisors photographed here, Dr. Paul Young and Dr. Aline Talhouk, as well as the amazing team of researchers, clinicians, and trainees who were instrumental in really progressing this work. And of course, special thanks to the study participants and the Patient Research Advisory Board. Thank you for listening.
Thank you so much, Dr. Dwayne. We only have a couple minutes left, but I saw there are two questions in the chat. One from Brian. Brian, are you still here? If you are, like maybe you can just unmute yourself and then elaborate a little bit more. I think your question might be, it's about like, I'm not sure if anyone is able to answer this question, but his question is like, he remembers seeing that on like MIT and then Your Brain on ChatGPT article, and it creates a lot of buzz. And then he thought like that article was a preprint and not like a peer reviewed, and at the scanning it also seems like not the greatest study design. So is there like maybe Michael, are you able to share some of your thoughts if possible?
All that is true. So it's important to follow the research as it evolves. I don't think we would ever look at one article and call it definitive, but it is a body of research that needs to be borne out, and I think that will be a really interesting thread to follow as it reaches peer review and probably more researchers look at it as well.
If I could add something really quick. So there's a really cool field of AI called explainable AI, which is really about like having AI systems explain itself. And I'm working with a couple of collaborators in that field. And a big important thing is really, you know, as we get these AI systems to work with clinicians or whomever else, that the AI systems don't just de-skill them and prevent them from learning or practicing their skills. So I think it is going to be a really good consideration, regardless of the validity of that one article. I'm very sure that this is going to be happening, so we do need to be careful.
Thank you. I think one more question from Delia. So he's adding AI, the data that is it generated by clinician directly, or is the data compiled by AI from public study or resource sources? Michael, maybe
It's possible to do both. In the case of what I showed, it's based on Cerner data. And so we have a private cloud environment to do that. That's being approved by privacy.
Thank you. Okay, it's 1 p.m. Thank you, everyone, who joined this session. The recording will be shared on our Digital House Learning Corner. The link is in the chat. So thank you. Thank you, John, Michael, and Dwayne. It's a great session. Hope everyone enjoy as well.
Thank you.
Thank you,
Thank you
Sally.
for having me.
Nunez.
Bye.
Thank you, Sally. Bye now.
Bye.